discussion and thought, a decision was made to disband the Midwest Surgical Society. Fortunately for our present society, Bill was persuaded to assume the presidency for the coming year. Under his leadership, the society was resurrected, its geographical base was expanded, and it has flourished ever since. He has served as the Midwest Surgical Association president from 1964 to 1965. And if you'd like to learn more about the Harridge Lecture, see additional information on the meeting app or the website. And now it's my distinct honor to be able to introduce my partner at the University of Virginia. I've been crowing about this meeting for well over 15 years to him, and finally had an opportunity to be able to get him to come up to one of our meetings. So Bruce Shermer has been on the faculty for his entire career at the University of Virginia since 1985. He serves as the Stephen H. Watts Professor of Surgery and is a vice chair in the Department of Surgery. He's been the division chief for general surgery and director of surgery nutrition support service. He was the program director for the residency at UVA for 17 years. Dr. Shermer has been a director of the American Board of Surgery and served in a variety of leadership roles with other surgical organizations. He was a governor to the American College of Surgeons and serves as an editorial board member of 6 surgical journals. He has also served on the review committee for surgery of the ACGME, being the vice chair of that committee for the last 2 years. Dr. Shermer specializes in treating patients with all types of abdominal and gastrointestinal disease. His current practice focused mainly on obesity surgery and laparoscopic abdominal surgery. Please welcome Bruce Shermer.
Well, Pete, thank you so much for that very kind introduction. It was pretty close to the way I wrote it. So, um, Pete's already talked a bit about the Harridge Lecture, and so I won't dwell too much on it. But what impressed me when reading about Dr. Harridge was the fact that he finished his residency in 1956 under the tutelage of Dr. Cole, and less than 14 years later, as a surgeon in private practice, in just 14 years, he rose to the rank of clinical professor and was given the Distinguished Service Award from the University of Illinois in just that short period of time. So quite an achievement, and certainly what he has done for this society was quite memorable in terms of his resurrecting it in 1964 from on the brink of extinction to become the vibrant society it is today. And I've really enjoyed the meeting. It's been great. Science has been wonderful. Hospitality has been great. And I want to thank you all so much for inviting me. I'm really quite honored to be here. So this is the way I want the title to look. The business of healthcare. Unfortunately, care is a little bit smaller than the dollar signs. And that's what we're going to talk about. I want to thank Pete for the honor of being here. I don't have any financial disclosures. I've long ago given those up. And this talk does contain some personal information from the UVA billing department, so discretion is advised. My sources for this talk really were a lot of reading, but also especially 3 books, and I recommend them all to you. They all were published around about 2020, between 2017 and 2021. American Sickness by Elizabeth Rosenthal. She's a person who's finished her medical training, but then went into work as a medical investigator of social issues. Works for a consulting firm in California. Dr. Uwe Reinhardt was not a physician, but he was a professor of economics at Princeton University, taught there for almost 50 years and was considered one of the country's experts on healthcare economics. He published his book in 2017, shortly before his death. And then finally, the book by Marty McCary. Marty's actually an HPB surgeon at Hopkins and has a busy HPB practice, but his academic aspects have been to look at healthcare, and he's published 2 books now and quite a number of articles looking at the price we pay for healthcare. Also, it's great these days to do internet AI searches. It comes up with data that you quite easily and you wouldn't expect. And as I said, some personal billing information. So when I thought about what I was going to talk about, one of the things that struck me was I've got 4 grandkids, and I was thinking about what are the problems that they're going to face in the U.S. of today. What will be left to the environment? How will disinformation be identified, which I think is a fairly new problem, only maybe a decade or so old. And more importantly for us, how will they afford healthcare? Because it doesn't look great if we keep going the way we're going. The other inspiration for this was my mentor, Dr. Scott Jones, and my mentor for my career. He actually addressed the American Surgical in 2003 and talked about this problem. And he said, in the first part of his talk, said, and I quoted, by the end of the 20th century, the medical profession was not organized, not sovereign, not autonomous, and did not control healthcare as they had during the middle to later part of the 20th century. He recommended in his talk that we should reinvent and reinvigorate ourselves as surgeons and follow a mission of placing the public and the patients first. And I think we've done that in many ways. We've certainly made operations great. We've improved outcomes. We've done some wonderful things in terms of the actual delivery of care. But this has not happened in the financial area, and that is because it's sort of out of our control right now, and it has been. Just as one data point from his talk was just over 20 years ago, the highest profit for any insurance company in 2003 was $935 million. Today, it's billions. United Health Group at 14.4. Look, those all together, it's about $33 billion. It's amazing how much profit. This is just profits. This is not sales. We spend in 2023 over $14,000 per capita on healthcare in this country. In 2000, the figure was only $48.45. It's tripled in just over 20 years. Not a good trend. Compared to other countries, we are number 1. That's not so great. We spend twice as much on average as all the other advanced countries in the world that are listed here, from Japan, Switzerland, Germany. Switzerland's the only one that comes even close at about 75% of our costs. But on average, we spend about twice as much for healthcare as all these other advanced and developed countries. Where is that cost from? Well, the biggest column is the one on the far left, and that is inpatient and outpatient care. We far outstrip those other countries in that area. We don't exceed them in long-term care or preventive care. We do exceed them in drug costs. And the administration is not really accurate on this because the administration of hospitals is not included in that small bar. So if you were to include the hospital administration, it would dramatically increase it. But you can see it's mostly in the inpatient, outpatient care, and as I'll show you shortly, it's mostly in the administrative costs of that care, not in the actual delivery of the care. So some really scary graphs starting about 50 years ago, 1970, 60 years ago. The total amount of, you can see both in actual dollars and in 2023 dollars, there's been a constant rise. I mean, this is somewhat of an exponential curve just in this time, what we spend on healthcare. Almost $5 trillion now in the next couple, it's predicted in 26 or 27, it'll hit $5 trillion. As a percentage of GDP, it's pretty close to, it's predicted it's going to be about 20%, just under 20% next year of our GDP is going to be on healthcare. That's 1 out of every $5. Quite amazing. And the only red slide I have in the whole thing is this one. In the last 40 years, healthcare spending has risen an average of 2.5% more than GDP. So if we keep going in another 10 years, it'll be 30% of GDP. Actually, even 15% or more, it'll be 35%. So it's now approaches 20%, and the trend continues. And the question is, how long can we sustain that? It also affects out-of-pocket expenditures. Not quite as much, but still, it's twice as much out-of-pocket expenditures per capita since 1970 than it is today. And well, this was in 2020. What do we get for that? No, we're not. We are not number one. Not even close. The death rate, I'm sorry, the life expectancy, you can see it's about 5 years difference between us and the other 10 countries. These 10 countries are the countries from Northern Europe and Australia. They don't include Asian countries. The premature death rate is significantly higher, almost doubled. The access to care, we're last among those 10, or 11th among 10 are superior to us. Equity of care, we're last. And health outcomes, overall, we are last. This is just a look at the age range from 15 to 49 in deaths. And this happened to be from 2021. So COVID was obviously a big influence. But if you take away COVID, we're still left with a huge increase in substance deaths, a huge increase in deaths from cardiovascular disease, transport accidents, significantly higher for way higher for homicide, and even chronic diseases like diabetes and kidney disease, we are higher than all those other countries. Our maternal mortality rate dwarfs that of all the other countries, with an average of almost 22 versus 4 deaths per 100,000. So in the clinical facet, we've done really well. We probably have an unrivaled, our physician force is extremely well trained. We deliver overall, compared to the rest of the world, excellent care. The delivery is a bit uneven, unfortunately. That's why our numbers aren't very good. The economic and regulatory facets, though, we have really fallen down. We spend about 30% of our healthcare money on administrative costs, and that number has gone up over the last several decades. It's the equivalent of over $4,000 per person per year just on administrative costs. Hospitals spend 40% of their money on administrative costs. Between 1975 and 2010, the number of physicians in the US increased by 150%, which is probably not quite as much as it should. The population grew a little bit more than that. But during the same time, the number of hospital administrators in healthcare increased by 3,200%, as shown on this graph. Quite a difference between the bottom line and the top line. This comes from McCary's book. As of 2019, every doctor serving in a hospital, for every doctor, there are 16 other individuals who work in the hospital. Of those 16, only 6 of them actually do any direct patient care. And most of the other 10 are involved in administration and billing. Traditional insurance plans, how do they compare in terms of what their administrative costs are? Well, actually, Medicare does pretty darn well. Traditional Medicare, their actual administrative costs are only 1.1%. There's no haggling with Medicare. They're going to give it to you or don't. They have a set price, bing, bing, that's it, 1.1%. Medicare Advantage plans, people decide to go ahead and use other options, that raises their administrative cost to 7%. And for private insurance plans, it's estimated at 13%. And that was 2018. That's just for the billing part. The Brookings Institute suggested several things that we can do to decrease administrative costs. We could have a better way to submit bills, make a clearinghouse where they're actually submitted in a standard fashion, which they're not. We could simplify prior authorization, which is a nightmare for people doing insurance, whether or not they can get prior authorization, how it works, and it's different for every different company. Quality reporting, we actually do a little bit better. This is probably the area that we do one of the best things, but trying, and you've seen in our science today, some of just the very last report, that the amount of improvement in mortality in my career in bariatric surgery has been amazing. So when we actually start looking at statistics and quality, we do pretty well with that. But getting that translated to all areas has not always been done, and we now have the electronic medical record, which could let us do that. And finally, exchanging data between institutions and interoperability. As you know, how many of you have gotten a patient comes to your clinic, they've driven 4 hours, they come in, their CT scan's not on the chart, you can't figure out what's wrong with them. and you have to send them home and come back another time when they get the information. It's just frustrating. We should be doing a better job of that. So this is a black and white slide for a good reason. This was the main ethical question posed by Uwe Reinhardt in 1997, quite a while ago. And I want to read it. As a matter of national policy and to the extent that a nation's health system can make it possible, and we could, should the child of a poor American family have the same choice of avoiding a preventable illness or being cured of a given illness as does the child of a rich American family? That is the choice we're trying to decide if we're making. And so far, America has not chosen a positive answer to that question. Essentially, what it boils down to is, are the better off members of society agreeing and willing to be made keepers of their poorer brothers in healthcare? And if you look at the rapid growth of healthcare and the growing inequality of the distribution of wealth in this country, that does not speak very well for the prognosis of the poor and the uninsured. And the uninsured's prognosis has actually just gotten worse in July, now that we're going to have even more people off of Medicare and with uninsured. The bugaboo of socialized healthcare. In the U.S., our immediate recoil to socialized healthcare is that it's not good, it's not going to ever work, it's going to be bad. Well, in fact, Medicare is a socialized payer system, and it's been successfully in place since 1964. And as I showed you, the costs of its administration are pretty darn low compared to everything else. The VA system, now dealing with them is not easy. Believe me, I understand that. VA system is a socialized healthcare system where the government owns and pays for everything. And so ethically, we seem pretty okay with that for vets. Why wouldn't something like that be okay for us? But maybe it shouldn't be, but necessarily, but I think it's worth thinking about. You know, if we're going to really come to grips with costs, this is something to at least come in the realm of thinking. Now, most countries have a socialized payer system where they cover everybody for certain basic things, and most basic healthcare is covered. But if you want to get extra things, or you want your operation a little quicker, or you want to go to somebody in private practice and get it done faster at a special place, you just pay extra, and that's about 10% of the population. That's true for just about all the other developed countries that I showed in the slides earlier. There's this common misconception that Medicare is not sustainable in its current form, when actually, if you do the math, it probably is. Given the growth rate of Medicare, the growth rate of payers, and so on. It could be sustainable for quite a while. But on the other hand, the tiers, the leaning and tendency that we're taking in terms of reimbursement now is forcing us as providers to offer a tiered care of service. In other words, there are so many practices that won't see Medicaid patients because they don't pay enough to the primary care doctor to cover their office costs even. So we're essentially forcing on patients a tiered system where we don't equally serve them, and they are not equally they do not have equal access to medical care. Now, just think about it. If we had a hospital that had one wing where there was bare bones, I mean, it was bare furniture, they barely had their chintzy curtains on the wall, they had 12 patients in a room, and it was really bare essentials of healthcare. And then the other wing of the hospital had all the luxuries, and it was a fancy and nice carpeted and so forth, private rooms and blah, blah, blah. How would that be perceived by the public? Well, it wouldn't go very well. It's not politically correct. However, the insurance policies we currently have and the reimbursements do, in fact, tierize system. And we do, in fact, deliver a difference of care to patients. We don't treat patients the same way based on their insurance ability as they should be. And it's, we don't do it in the furniture, but we do it in the billing. Medical debt. That is just a huge problem. That, I think, is really going to be the thing that turns it. This is going to be what we have to deal with, and we're not going to be able to deal with it after a while. In the U.S., about over half the people have deferred medical care in at least one instance due to the result of medical debt on one very recent survey from last year. That's a pretty significant influence on healthcare, and that's probably why our numbers are not very good. 70% of U.S. adults say they receive medical bills they can't afford. Over 500,000 Americans file for bankruptcy every year due to medical bills, and that represents 2/3 of all the bankruptcies that occur each year for medical debt. There are 14 million adults that owe over $1,000 and 3 million who owe over $10,000. And the cumulative amount of debt in the U.S. is estimated that 100 million U.S. adults currently owe about $220 billion nationwide in medical debt, current or deferred. The Consumer Financial Protection Bureau, this got so bad that last year in the Biden administration, they actually removed medical debt from credit reports so people wouldn't be ruined forever in terms of having medical debt, and it was so common. But that actually was, that budget for that office was cut just 46% this month by the new administration's bill. Now, I just give you guys one of the things that got me interested in this was, I've gone through 2 years of being sick. I've had lymphoma and then leukemia. I had a stem cell transplant, and I was curious just to see what my hospital bills were. So I got my bills from 2000. So I got my lymphoma in 23. I had treatment for 23 to 24, and then I was okay in 24 in April. But then in August of 24, I got the leukemia rather. I had to have a stem cell transplant in January of 25. So for my bills from 24 and the first half of 25, $854,000 without any physician costs. Can you imagine? Can you imagine? I mean, if I didn't have insurance, I wouldn't be standing here. I would be dead. There was one visit that I had for just 8 hours. I was chemotherapy toxic, and I felt sick. I knew it was that, but I went in extra, wasn't a scheduled visit. Spent 8 hours in the outpatient center. I got 2 liters of saline, 1 unit of blood, and it happened because it was when I was still hadn't reached my deductible, so I saw the bill. For that 8 hours was $14,000. Dr. Rosenthal, in her book, really came up with 10 things that are the problem with America's healthcare system. I'll go over them with you. And I won't give you examples because there are plenty of them in her book, but more treatment's always better. Default to the most expensive care. We heard about that in two of our talks today in terms of how we're going to, give and I'll give you a personal example. After I had my most recent bone marrow biopsy and I was in remission, I had a hematologist sit down with me and say, well, you're in remission, but we could give you more chemotherapy if you want. And I said, well, what's the data on that? He said, well, it doesn't really improve survival. And I said, well, why would we do that? He said, well, it's something if you want to do it, we could do it. No, I don't want to do that. Really? A lifetime of treatment is preferable to cure. There are a number of diseases that probably could be treated with vaccines or other investigations, but because they're not common diseases or because the treatment for them currently is generic, it's not worth putting the R&D because it's not profitable, so they're not going to be investigated. Amenities and marketing matter more than good care. Not-for-profit hospitals have to spend their money somewhere. So they do lots of money. They make nice entryways. They make nice valet parking. They do lots of things to help their patients, and it's a great experience for patients, but it doesn't improve healthcare. And as technologies age, prices can rise rather than fall. Think about what TVs cost relative to our budget 15 years ago and what they cost now and how much better they've gotten. But, that's not true in healthcare. We're actually paying more for some of the operating room equipment than we did 15 years ago, and it's pretty much the same stuff. There's no free choice for Americans. They're stuck buying American for our patients. Now, that's not altogether true, because in McCary's book, he's saying that actually, if you go to Pennsylvania now and you talk to the Amish community, whenever they get sick, they get on an Amtrak and they go to Mexico to get their care because they want to pay their bills right away and they can't afford anything in the U.S. So medical tourism, I think, is saying that's not necessarily true, but for the most part, we're stuck buying, especially when it comes to drugs and things like that. More competitors vying for business can drive prices up, not down. That's not the way typical markets work, but in the medical business, it does happen. Economies of scale do not translate to lower market prices, because the companies that develop monopolies, they don't drop their prices. They actually increase them. And now the big three. There is no such thing as a fixed price for a procedure or test. And all you have to do is start looking around at various hospitals and what they charge. And what's weird is that you don't know. You know, you go in, if you get sick and go into a local emergency room, they're not going to tell you what they charge for you. And if you have to have a procedure done emergently in another hospital, they won't tell you what they're going to charge. You get your bill 4 months later and find out what it's going to be. And you hope that your insurance covers most of it. But if it doesn't, you're stuck. I mean, but you have no way of knowing ahead of time. Can you imagine if we went into a store and you said, well, I want a dozen oranges, it's going to be, how much is it going to be? I can't tell you. And a week later, you get a bill for $70. I mean, how crazy is that? Think about it. There are no standards for billing, and prices rise to whatever the market will bear. So now, this is from McCary's book. He's an HPV surgeon. Some hospitals mark up the charges of a procedure 25 times more than Medicare will pay. And it varies from hospital to hospital. Insurers demand bigger discounts every year from the hospitals, so they make more money, and in turn, the hospitals then increase their price more. And this is all done. It's all done behind. We don't. It's a veil of secrecy. Nobody really knows how and why this happens. When I looked at my medical bill, I couldn't figure out why some CT scans were discounted this much and how they were. And it's a morass. You cannot figure it out. It is impossible. The net bottom line, though, is that increased costs going back and forth in this bargaining does get passed on to patients. And it's just inequitable from hospital to hospital. There's no pattern to how much they'll mark up their bill. Many main victims are the real people that get slammed are if you're the working poor. You earn too much to qualify for Medicaid and you don't have very good insurance. And have you ever tried to do a self-pay procedure at your hospital is going to charge them a huge pay. The numbers are staggering at my hospital. I mean, I tried to do a bariatric gastric bypass operation. They want to charge the patient $35,000, $40,000. Now I know that from insurance, they're going to get about $15,000 or $20,000 at the most, but they're going to charge a patient who doesn't have insurance $40,000. It just doesn't make any sense, but that's their price, but that's not what they really get paid. The hospital, and what's even worse now is this has been going on for a while because hospitals actually will sue patients for medical costs. In Virginia, in our state, 37% of the hospitals sued patients in 1 year during the last decade. And not-for-profit ones are actually more likely to sue than for-profit ones. And, badge of dishonor to our institution, prior to 1921, when American Sickness book came out, there was this story about a UVA patient, and I think that's what really sparked the controversy, because all of a sudden, people in the faculty and the community started looking into the UVA's billing practices, and we found out that UVA was doing a lot of this. And it turned out they actually sued 36,000 patients over a 6-year period. That's 6,000 a year. That's like over 100 a day. For over $100 million in back dues. They stopped the practice in 1921. This article from the Richmond Times actually was comparing UVA and VCU, and VCU has actually not only stopped it, but they also stopped the liens on patients' mortgages and houses and things. UVA still has liens on patients' houses. So in other words, if you had medical debt and they had a lien on your family's house, if your father dies, your parents die, and you think you're going to be able to get the money from the house, no, UVA is going to take it, and those liens will go forward for another 20 years. So the other thing that's really bad is surprise bills. If you go to an out-of-network provider, you're going to get slammed. You're going to get a difference. They can charge you whatever they want, and if your insurance only covers what the network would cover, you're going to be up on a hook for the difference. And they won't tell you ahead of time what that is. You have no way of finding out. The most common areas that this occurs are lab tests, radiology, anesthesiology, and pathology. And in one study that was done just a couple of years ago, over 50% of patients in one state in New Mexico got a surprise bill in 1 year for health care. The medical transport industry is another ripoff. When I was a kid, the ambulance came for free and they took you to the hospital. Now most of the ambulances are charging, but it's the air ambulances that are really gone crazy. The number of air ambulance companies increased by 1,000% from the 1980s to 2017. The average price of an air transport in 2007 was $13,000. By 9 years later, it was $50,000. Do you guys know what a health insurance broker is? I didn't. It's the guy who sells insurance to the employers. Say is the guy who sells Aetna policy to UVA. That guy gets a big bonus for selling it, plus 1 to 4% of all the revenue the company pays to the insurance company. It's essentially a huge kickback. They can fire the agent if the company will fire the agent if he recommends anybody else. And so there's this system. You can't break the system. It's going to get more expensive and more. Now, finally, there are some companies like Health Rosetta, which now certifies brokerage firms who have transparency for their costs and charge only flat fees for selling insurance. But that's the exception to the rule. Most of them are still done by these focused agents hooked to one company. Last year in the U.S., employers and businesses paid $738 billion for healthcare for their employees, and that's going up about 5% per year. These all the costs come out of the employees, and what is the employer going to do? They're going to still make money, so they're going to pass that cost on to their employees instead of giving them a raise for their wages. That's why wages haven't gone up much. They just pay more for healthcare. You guys know what a pharmacy benefit manager is? I didn't. The pharmacy benefit manager is the guy who buys the drugs from Merck and sells them to the hospital or the hospital plan or the insurance, and they can mark that up 5 to 20 times. And the employer won't know what the markup is, because the only thing the employer gets at the end of 3 months or 6 months is this huge list of medications and what they are charged for them, but they don't get what the PBM paid for them. So they can do any kind of manipulation they want, and employers get this list of drugs, and it's very confusing. So they just pay it. How can they figure it out? They even have, up until recently, the pharmacists were prohibited from even giving patients advice on how to, negotiate for better drugs and find places. But now that's finally ending. Some of the PBMs even have their own pharmacies, so they make money on that end too. They make money on the retail side, not only on the wholesale side. And if you get on they get you on a mailing list, then they just send a notice to the doctor's office, and they automatically renew your prescriptions, even though you don't need them or want them, and that's more money for them. Health insurance companies own the largest PBM groups, and the biggest 3 PBM groups control 85% of the drugs sold in the U.S. So when we're talking about the high price of healthcare and why drugs cost more in this country than other countries, it's not necessarily because the companies, granted, the U.S. drug companies make more than they make more money in the U.S. than anywhere else. That's where they pay for their R&D and all their profits. But in addition, they also have this huge amount of money that we pay to the PBMs to get the drugs even to the pharmacy, and our employers pay for it. Enough for PBMs. Now, are we part of the problem? Well, yeah, sometimes. So we have to be careful about what procedures we do. And now this applies to the vast minority of people who are doing healthcare, but there are people who do excessive procedures that aren't needed or are unscrupulous, don't work. And this is from McCary's book. He went to to Washington, and with these church fairs on Sunday, where these guys with ultrasound people's legs, and they would send them to get their angioplasty for asymptomatic peripheral vascular disease. Related stories about there's this procedure to balloon dilate patients with sinusitis. It works 5% of the time. Surgeons who do back pain before they ever send a patient for a trial of PT. The Mohs procedures, if you do them in 4 stages, you get paid a lot more than you do them in 2, and they work just as well. Excess re-excision of breast biopsies. Too many hemorrhoids get banded. Separating upper and lower GI scopes so you can bill for 2 different procedures and get more for procedure fees. For location fees. Pediatric umbilical hernias. people who close them routinely before age 5. End-of-life oncology, patient who's, expires and has been on chemotherapy 2 days ago. And surgery for claudication. These are just some of the things that are given and illustrated. Now, most of us don't do that, but we do contribute a little bit to the problem. We definitely overtreat a lot of things. Too many opioids. The average Medicare patient now is on 12 medications. And over the past 15 years, that has doubled. We overtest too many times prior to minor surgical procedures. We do excess radiologic studies, especially if we listen to the radiology recommendations. How many times in your career have you gotten an MRI and they say recommend a CT and vice versa? Almost all the time. It's crazy. Excess thyroidectomy, we heard a little bit about excess thyroidectomies can easily be done now, genetic testing is doing it. But for a period of time, about 5 years ago, and especially in Asia, there were a lot of them that were done unnecessarily. And, we blame, when we sit here and we have our medical meetings to try to make things better, we blame things like line infections and medical mistakes for the main problems that are causing healthcare, but it's not. It's not the main problems. That's a small part of it. And it can be fixed, and we should fix it, and we are fixing it. But they only are a small part of the issue. The main issue and the real problem is the cost of administration and the cost of the burden of paying the bills. And as I showed you, 40% of the healthcare costs are administrative, and we have no effect on that. Other countries with a single-payer system have more regulated systems, and they can deliver better quality care than we can, or equal quality care with half the price. We're the leaders in health research and innovation, but we are certainly not the leaders in transmitting that excellence to our population. So we could do some things better. We could, some recommendations that came out of these books and other articles that I've read, if we just simply standardize healthcare, if everybody knew what the price was going to be, it would be amazing. You would actually know what you're paying for what you do ahead of time. There could be a healthcare blue book. Florida has passed a law requiring hospitals to show the average price of what they are being paid for a procedure, not what they charge, because we know their charges can be out the roof, and what the insurance companies actually pay them are much less. There are similar laws now for New Hampshire, but those are the only 2 states that I know of. Maryland is the only state in the country with an all-payer system for hospitals. In other words, hospitals charge the same rate for a procedure no matter what your insurance company is. They all have to pay the same rate. And I don't know how Maryland got that exception, but they have, and it's working very well for them. It saves Medicare. Even Medicare, it has the lowest rates. It saves them millions of dollars a year. We could be more oriented toward a patient care-centered model. This comes from McCary's book. These are kind of like going back to HMOs, which had their problems. It didn't really work, but he's suggesting that maybe if we revisit them, we could have some There's this group called the Iora Healthcare. They basically take a number of patients, and they just pay a certain fixed price for them, and they take care of them, and they take all their problems. They take care of them in-house. Obviously, the only problems that comes up is you have special issues, and so that's not perfect, but it's at least a start and potentially a thought on a solution. For medications, we could use one things we can do now. We can use things like GoodRx. We can use online services. Don't be afraid to look for other non-insurance bill costs. Sometimes it's better to get your drugs outside your insurance coverage, because your insurance coverage could be marked up by the PBM and be much higher than if you pay without. There's outfits like healthwarehouse.com, which can give you in discounts, and other online pharmacy discounts. Fortunately, I will say that surgeons are not a big part of the problem. If we look at 1975 compared to today, our average income has only gone up about 23% over 50 years, which compared to the rest of the healthcare field is not very much. It's not zero, but it's not very much. So we can feel a little bit good about that. But what I will say is that there's no question that we as physicians have a much less voice in what's happening to healthcare. 40 years ago, the chairs of medicine and surgery were pretty more powerful in the hospital. They made a lot of decisions. They had control over finances. They had control over money. Now many chairs are middle managers, and physicians have little role in determining hospital policy in many cases. If you do, consider yourself fortunate, because most of us don't. Only 5% of hospitals have MDs as CEOs. There's been some articles, those hospitals do a little bit better than than the average hospital. These are just some chilling, not chilling, but just a little bit disturbing numbers. And just since 2019, the number of physicians employed by hospitals has gone up from 62 to 77%. And most of our graduates now are taking jobs as hospital employees. The private practice groups have kind of gone away, and if they haven't, the hospitals are working hard to squeeze them out because they don't want any competition or voice interfering with what they want to do. So finally, what's wrong with this picture? Starbucks spends more on healthcare than coffee beans. GM spends more on healthcare than steel. Healthcare is usually the second largest expense for most employers after wages. Wages and healthcare. That's more than supplies. They pay more for healthcare than they do for the supplies of what they're making. Whereas, and in service industries, obviously, it's the second largest. The major reason wages have not kept pace with inflation for the past 20 years is because the employers are having to pay more and more for healthcare, and that's where the money's going. And pharmacists now are finally breaking loose of some of the gag rules that kept them from being able to advise patients. That fortunately did happen. I talked to you about the pharmacy brokers. They actually got exempted from essentially what's a kickback by a special law that was passed back in 1987 that allows them to still do this and take kickbacks, as well as insurance brokers. So those laws are on the books that allow them the exception and free them from any penalties. So it would take $40 billion a year for just 5 to 6 years to eliminate world hunger. That's by best estimates. Think about that. Eliminate it. Last year, the top 6 insurance companies had a profit of 33, that should say billion, I'm sorry, close to what it would take. And we spent $840 billion on defense last year. So if we took 5% of our defense bill and put it towards stopping world hunger, we could do that. So we can continue to go the way we're going, or we can try to start making some changes. And I think the most important thing I want you guys to take away from this talk is just maybe some of the things that you didn't know about. I mean, I never heard of an insurance broker. I never heard of a pharmacy-based broker and all that stuff that's going on. Why does administration cost so much? You know, there is no evidence-based method of administration. Do you ever see any articles on evidence-based administration, how it's going to make? No, there's no, it's the Wild West out there in terms of the C-suite. Those guys are doing whatever they want. And, you know, it's gonna bite them in the ass, but it's gonna bite us in the ass too. We can't let this keep going. I mean, the rise in healthcare, it's 20% of GDP. When is it gonna stop? It's gonna break us at some point, and we might as well start realizing it and getting informed about it so that we can help raise a voice, an informed voice from the medical care side that will help our patients. So we need to consider the cost of tests, equipment, procedures, avoid routine tests. And, you know, we have to realize that we could perform the best operation possible for the patient, but if they get a hospital bill 2 months later that breaks them, what have we done for them? We haven't, and their lives are worse off. They might be better. They might be able to walk better. They might be able to be smaller and be healthier, but they're broke. So it's terrible. The first step to correcting the egregious system is really for us to understand the mechanisms of why our patients have to pay so much money and for us to stay informed. And, you know, the affordability will create a major crisis. We need to be informed how to address it. We need to understand how it works. We need to start reading articles about healthcare, and we need to educate ourselves and our residents. Without us being knowledgeable, we'll never make any changes, and we need to make changes. Thank you.
During your speech today. Thank you. Great. Thanks. All right. I think That's it for the meeting for this morning. Go out and enjoy your free time. And we have the reception on the porch and then Noni Lowry dinner dance this evening. Thanks.